The aim of this video is to look at action potentials in the pacemaker cells and explore a few things which may affect how these cells work in a clinical context. The heart is a pump, and it is stimulated to pump by an action potential. Since we need our hearts to pump consistently and regularly, the pacemaker cells are extremely important. These cells make up approximately 1% of the cell population in the heart, and they are predominantly located in the sinoatrial node, which acts as the primary pacemaker in the heart. The sinoatrial node sits comfortably in the right atrium, and roughly speaking, it has an intrinsic resting rate of around 70 to 80 beats per minute. There are, however, other pacemaker cells dotted around the heart, and this is important as a backup in case the sinoatrial node isn't working properly. Pacemaker cells in the AV node, or the atrioventricular node, sit at around 40 to 60 beats per minute. Cells in the atrioventricular bundle, otherwise known as the bundle of His, can work at around 20 to 30 beats per minute. And cells dotted around the subendocardial branches, also called the Purkinje fibers, can generate a heart rate of around 10 to 20 beats per minute. These pacemaker cells differ from other cells which elicit an action potential, such as muscle or nerve cells, in that pacemaker cells are characterized as having no true resting potential, but instead they generate regular, spontaneous action potentials. Another difference is that the depolarizing current is carried into the pacemaker cell primarily by a relatively slow calcium current, instead of the fast sodium currents seen in normal cells. There are, in fact, no fast sodium channels and currents operating in pacemaker cells. This results in a slower action potential in terms of how rapidly they depolarize. Therefore, these pacemaker action potentials are sometimes referred to as slow response action potentials. Action potentials in pacemaker cells can be divided into three phases. Phase 4 is the spontaneous depolarization or pacemaker potential that triggers the action potential, once the membrane potential reaches threshold between -40 and -30 millivolts. Phase 0 is the depolarization phase of the action potential, and phase 3 is repolarization. Once the cell is completely repolarized at about -60 millivolts, the cycle is spontaneously repeated. The funny or slow sodium channels and transient or T-type calcium channels are involved in phase 4. Phase 0 is predominantly the long-lasting or L-type calcium channels, and phase 3 involves the movement of potassium. The changes in membrane potential during the different phases are brought about by changes in the movement of ions across the membrane through ion channels that open and close at different times during the action potential. When a channel is opened, there is increased electrical conductance of a specific ion through that ion channel. Closure of the ion channels causes the ion conductance to decrease. As ions flow through open channels, they generate electrical currents that change the membrane potential. Let's imagine a cell from the sinoatrial node in isolation and look at what happens during each phase. At the end of repolarization, when the membrane potential is very negative, about -60 millivolts, ion channels open that conduct slow, inward, or depolarizing sodium currents. These currents are called funny currents and can be abbreviated as I subscript F. These depolarizing currents cause the membrane potential to begin to spontaneously depolarize, thereby initiating phase 4. As the membrane potential reaches about -50 millivolts, the T-type calcium channels open. As calcium enters the cell through these channels down its electrochemical gradient, the inward directed calcium currents further depolarize the cell. And when the membrane depolarizes to about -30 to -40 millivolts, the L-type calcium channels open, and so begins phase 0. During this phase, more calcium enters the cell, which consequently further depolarizes until an action potential threshold is reached at around +10 millivolts. Phase 3 is where repolarization occurs, as potassium channels open and the L-type calcium channels become inactivated and close. This goes on to approximately -60 millivolts, and the process begins again. During phase 4, there is also a slow decline in the outward movement of potassium, as the potassium channels responsible for phase 3 continue to close slowly. Although pacemaker activity is spontaneously generated by the pacemaker cells, the rate of this activity can be modified significantly by external factors such as autonomic nerves, hormones, drugs, ions, and ischemia or hypoxia. We'll spend the second half of this video looking at how the pacemaker cells are regulated. Left to its own devices, the sinoatrial node displays intrinsic automaticity at a rate of around 100 to 110 action potentials per minute. That means that with nothing else acting on it, the sinoatrial node would cause a resting heart rate of 100 to 110 beats per minute. However, this intrinsic rhythm is primarily influenced by autonomic nerves, with vagal influences being dominant over sympathetic influences at rest. This vagal tone reduces the resting heart rate down to 60 to 80 beats per minute. The sinoatrial node is predominantly innervated by the efferent branches of the right vagus nerves, although some innervation from the left vagus is often observed. To increase heart rate, the autonomic nervous system increases sympathetic outflow to the sinoatrial node, with concurrent inhibition of vagal tone. Inhibition of vagal tone is necessary for the sympathetic nerves to increase the heart rate, because vagal influences inhibit the action of sympathetic nerve activity. The sympathetic activation releases noradrenaline and increases pacemaker rate by decreasing potassium and increasing the slow inward calcium and sodium. These changes increase the slope of phase 4, so that the pacemaker potential more rapidly reaches the threshold for action potential generation. Parasympathetic or vagal activation releases acetylcholine into the sinoatrial node and decreases pacemaker rate by increasing potassium and decreasing the slow inward calcium and sodium. These ionic conductance changes decrease the slope of phase 4 of the action potential, thereby increasing the time required to reach threshold. Vagal activity also hyperpolarizes the pacemaker cell during phase 4, which results in a longer time to reach threshold voltage. Pacemaker activity is also altered by hormones. For instance, circulating adrenaline causes tachycardia by a mechanism similar to the noradrenaline released by sympathetic nerves. And thyroid hormones increase heart rate, cardiac contractility, and cardiac output. Therefore, hyperthyroidism induces tachycardia, and hypothyroidism induces bradycardia. Thyroid hormone has a consistent positive chronotropic effect, and resting sinus tachycardia is the most common cardiovascular sign of hyperthyroidism. There is also an increased incidence of atrial fibrillation reported in patients with overt hyperthyroidism. Thyroid hormones influence specific ion channel proteins in the sinoatrial node, and this affects the sodium or funny channels and both the L-type and T-type calcium channels. Cellular hypoxia, usually due to ischemia, depolarizes the membrane potential, causing bradycardia. Without adequate oxygen, the ATP-dependent ion pumps in the cell membrane cannot operate. This leads to a loss of normal ion gradients across the membrane that are required to produce a negative membrane potential. Because a hyperpolarized state at the end of phase 3 is necessary for pacemaker channels to become activated, pacemaker channels remain inactivated in depolarized cells. This suppresses pacemaker currents and decreases the slope of phase 4. Various drugs, often used as antiarrhythmics, also affect the sinoatrial nodal rhythm. Calcium channel blockers, such as verapamil and diltiazem, cause bradycardia by inhibiting the slow inward calcium currents during phase 4 and phase 0. Drugs affecting autonomic control or autonomic receptors, such as beta blockers and muscarinic antagonists, can directly or indirectly alter pacemaker activity. They primarily work as an antagonist to the adrenergic receptors, and so block the ability of noradrenaline or adrenaline to bind to the receptors. This reduces sympathetic action on the pacemaker cells, and so limits the increase in firing rate. Drugs affecting parasympathetic functions can be classified into those that increase or decrease activity at postganglionic terminals. Parasympathetic postganglionic fibers release acetylcholine, and the receptors on the targets are muscarinic receptors. Parasympathetic drugs can be either muscarinic agonists or antagonists, or have indirect effects on the cholinergic system. atropine, and scopolamine, are part of a class of muscarinic antagonists. They come from the Atropa genus of plants that include belladonna or deadly nightshade. Digitalis causes bradycardia by increasing parasympathetic or vagal activity on the SA node. However, at toxic concentrations, digitalis increases automaticity and therefore can cause tachyarrhythmias too. This toxic effect is related to the inhibitory effects of digitalis on the membrane sodium-potassium ATPase, which leads to cellular depolarization, increased intracellular calcium, and changes in ion conductances. Ivabradine is a medication used for the symptomatic management of stable heart-related chest pain and heart failure, not fully managed by beta blockers. Ivabradine acts by reducing the heart rate via specific inhibition of the pacemaker current, a mechanism different from that of beta blockers and calcium channel blockers. It does this by selectively inhibiting the pacemaker or slow sodium or the funny current in a dose-dependent manner. Blocking this channel reduces a cardiac pacemaker activity and selectively slowing the heart rate and allowing more time for blood to flow to the myocardium. This is in contrast to other commonly used rate-reducing medications, such as the beta blockers and calcium channel blockers, which not only reduce the heart rate, but also the cardiac contractility. Given the selective decrease in rate without loss of contractility, ivabradine is very useful for treatment of congestive heart failure with a reduced ejection fraction. That's all we have for this video. Thank you for listening, and I hope you find it useful for your studying. We'd very much appreciate any feedback that you may have.